Good afternoon, everyone, and I, Dr. Ananya Prabhu at NITRD, welcome you all to the 112th session of our e-NISCHIT. E-NISCHIT is our platform where our endeavor is to share knowledge, impart knowledge, and understand it and imbibe it. So that's our endeavor, and we've been doing it from the past 112 sessions, as you all know, and that's our motivation that keeps us going forward. And I welcome you all. I welcome all the ART centers from Andhra Pradesh, Arunachal Pradesh, Assam, Delhi, spread across the India, Meghalaya, Mizoram, Northeast, Tamil Nadu, Sikkim, and of course Uttar Pradesh, West Bengal, and Delhi. So on the behalf of my team from Share India, Dr. Jyoti and Mr. Rakesh, we welcome you all to today's session. Welcome to all the ART staff who have joined us. And today is going to be a very, very interesting case, because what we are going to deal with today is a very, very practical problem of recurrence of TB, and that recurrence of TB is very common even in normal population, but how important it becomes in HIV population, that everybody, all of us sitting in ART centers know. So for that, I'm very thankful, and it's a proud privilege that we have our expert today with us, Dr. Saini, J.K. Saini, sir, who's a very, very eminent name in the field of tuberculosis, as well in the field of lung cancer. He's the head of the Department of Pulmonary Oncology at National Institute and TB Respiratory Diseases. Thank you, sir, for joining us today. It's indeed a privilege that we'll be hearing you today. And I also thank the case presenter, Dr. Sundaresan, who's a senior medical officer at Coimbatore, for sharing such an important case. Thank you for sharing the case, because I'm sure all of us would learn a lot from that discussion. What important point you have pinpointed today. So basically, where we are going towards in this our main agenda today is that what we want is, because we have such a great faculty, great expert with us today. So I'm very sure that by the end of the session, we would understand that, yes, we are dealing with this great problem of tuberculosis reinfection, but how far and how are we placed in TPT, that is tuberculosis preventive treatment. All of us know this name, but we really don't know how practically, whether we are not confident, we are not so sound when we are sitting in a ART center, whether it will really work, especially in the case when you have already given the ATT. Everybody has this doubt, what will now this drug do when the patient has already taken the tuberculosis drug? So we couldn't have found a better expert, and I'm very happy that we have Dr. Saini, who will be clearing those doubts with us. So I think we can go ahead with our today's agenda now. So first, we will be having the case presentation.
Good afternoon to all. First, I thank all NACO and others for giving this opportunity to present this case. Today, I came with the case of 62 years old male. He is attending in our ART center at Coimbatore on the last day of 2018, that is 31/12/2018. He came with a history of cough with HIV positive. We do the counseling and a basic investigation we are done. He has the no history of diabetes, hypertension, and previous history of tuberculosis. He is a smoker and not an alcoholic. After counseling, we do the basic investigations, and for TB, we are doing the chest X-ray and the sputum CB naught. After report came, the chest X-ray shows normal. The sputum CB naught shows rifampicin sensitive and MTP detected high. So rifampicin is highly sensitive. So we started ATT for the patient on category 1 ATT. All other blood investigations shows normal. So we started as category 1 ATT on 31/12/2018. The patient continue ATT for 15 days. After that, no drug. After that, we started ART with the TLE regimen. After 15 days of ATT, he continued ATT with ART for 6 months. He completed the intensive phase and the completion phase. The results are so negative. Then he declared as cured after 6 months of ATT on 2019. So after completing ART, as per our guidelines, we started isoniazid prophylaxis. The patient started with isoniazid and also pyridoxine for 6 months. He completed the IPT as well also. After that, the patient symptomatically improved. The patient CD4 is also improved. The first CD4 is 322. After the 6 months of ART and ATT, CD4 is improving 540. The viral load is also after 6 months of ART, so target not detected. That means within 1 year he completed the first episode of ATT and also IPT. So after that he continued the ART for till now. After the 2 years he became LFU. In meantime he became LFU for 15 months. We tracked the patient. He reverted back after 15 months of LFU. Then again we do the basic test and investigation. Again X-ray shows TB. That is X-ray shows pulmonary. X-ray shows pleural effusion with lower lobe infiltration on February 23. We get the thoracic medicine opinion. We started ATT on category 1 second time. That means I want to trust this. The patient completed the episode of ATT in 2019. Again, he got completed IPT in 2019. After that, in 2023, he got again TB. That means after completing IPT, the second episode of TB is secured. The second episode of TB, after that, we started category 1 ATT. We continue the ATT from February 2023 to 6 months. On the August 23, he completed second episode of category 1 ATT. So at that time, we started TLD regimen along with the extra dose of TTG. The first patient is on TLD regimen. After LFU, he reverted back. We started with the TLD regimen. The patient diagnosed as TB positive and started ABT. So we added additional dose of DTG. So the patient continued on TLD and DTG regimen. After completing the TB, the patient continued on TLD regimen. The CPT is given on the episodes of TB throughout the period. After completing second episode of ATT, the patient still now in our follow-up, the patient continues still in ART regimen. The patient is on TLD regimen. Now the patient shows improving. The patient CD4 and viral load is also improving. The latest viral load shows 1600. So somehow adherence issues there. We are on patient as a step-up counseling. So we will do after 3 months of viral load, it may improving. So I want to present this case in this area because mainly the IPT completed patient, the TP recurring is secure. In last week, we received the new guidelines regarding the TPT. So we want to know how much of its effective and how much is completed. That's why I was presented. In our ART center, around 80% of patient TP preventive secure with IPT. So I want to present this case for this only. Thank you.
So thank you for sharing your case with us, and it was a good worked up case. So the patient was lost to follow-up for 15 months.
Yes, madam. In meantime, lost follow-up for 15 months.
Okay, so patient was not there. So that's when the picture worsened. This case is fairly simple. The patient had received ATT and ART in 2019. Then after completion of ATT, the patient even received a TPT for once. And then the patient was that time patient was put positive for TB, and he had completed the ATT treatment. He had completed even the TPT treatment, but then he was lost to follow-up, and then he again presented with the symptoms this time, which seemed like sputum smear negative pulmonary TB, and X-ray showed pleural effusion in February 2023, and he was started on ATT on CAT1. So the burning question here is that when the patient got the ATT also and the patient got TPT also, so why did the TB infection come back? That's what we want to know, and that's where you want to know the field reality of tuberculosis preventive treatment. So it's a very, very good question being asked today.
And now we request our expert today for the directing.
Hello everyone. At the very outset, I thank e-NISCHIT team for giving me this opportunity to deliver this didactic on this important topic of TB preventive treatment in people living with HIV. So, people living with HIV have a higher risk of developing TB disease compared to general population, even when on antiretroviral therapy and with high CD4 cell counts. The combined use of TPT and ART has been shown to reduce TB incidence and mortality among people living with HIV, including among those with higher CD4 cell counts. TPT also provides additional protection when given immediately after the successful completion of treatment for TB disease in people living with HIV, like this case we just discussed. So we will come back again on this post-treatment TPT, how effective it is. TPT should be core component of the package of care for people living with HIV. So we can see that as per TB strategy, the pillar 1 and pillar 2, TB preventive treatment fits within a larger framework of preventive actions envisaged by pillar 1 and 2 of TB strategy, ranging from active TB case finding, infection control, prevention and care of HIV and other comorbidities and health risks, access to universal health care, social protection and poverty alleviation. If we see this graph, we can see if at baseline there are 1,000 cases per million of population, and if we take care of these cases just by mitigating the risk factors, then we can see here the first graph, which is pink one, mitigate risk factors. So our effort should be to bring this graph to the baseline as early as possible. That is our TB strategy line. You can see here 90% by 2035 as per SDG goal, and as per our national goal by 2025. So only mitigating the risk factor is not effective as we were doing before the chemotherapy era. Now another intervention can be the prevention of infection only. So that alone will not be sufficient. Then third intervention is treat TB disease only. Again, we can see that there is already there is flattening of the curve, and it is not coming down up to our end of the strategy line. And then treat the TB infections alone is also not sufficient. But we can see this last line, which is the black one. If we treat the TB disease and TB infection both, then we can achieve our TB strategy goal of reducing the TB incidence by 90% as compared to 2015 by the year 2035, and as per our national this targets by 2025. So it is very important not only to treat the TB disease but also the TB infection to achieve our target of eliminating TB by 2035. So the critical steps of TB preventive care pathway are: identify the people at risk, rule out TB disease first before initiation of TB preventive treatment, test for TB infection in population where it is required, and options for different TPT regimens. So recently, at the 12 days back, these new guidelines have been launched by WHO for this tuberculosis and comorbidities, including HIV and TB. So as per these WHO guidelines, who are eligible for TB preventive treatment? Adults and adolescents living with HIV who are unlikely to have active TB should receive TB preventive treatment as part of comprehensive package of HIV care. Treatment should be given to those on antiretroviral treatment, to pregnant women, and to those who have previously been treated for TB, irrespective of degree of immunosuppression, and even if latent TB infection test is not available. So in this population, we don't need to do the testing for latent TB infection, like MON2 test or IGRA test. So it is there is strong recommendation for this and high certainty in the estimates of event. So adults and adolescents living with HIV who are screened for TB according to a clinical algorithm and who report any of the symptoms of current cough, fever, weight loss, night sweats, the 4 symptoms, screen, may have active TB and should be evaluated for TB and other diseases and offered preventive treatment if active TB is excluded. This also has a strong recommendation. Then chest radiography may be offered to people living with HIV on ART and preventive treatment be given to those with no abnormal radiographic findings. So as per these latest published or launched WHO guidelines, this is the algorithm to rule out TB disease in people living with HIV. First, screen for TB. Then if TB screen results are negative, then check for any contraindication for TB preventive treatment. If there is no contraindication for giving TB preventive treatment, then give preventive treatment using different regimens which are available country to country. And if there's some contraindication is present, then deferred preventive treatment, follow up for TB disease as necessary, even for people who have completed preventive treatment. So what are the contraindications for starting TB preventive treatment? Including acute of chronic hepatitis, peripheral neuropathy if we are treating with isoniazid based regimen, regular and heavy alcohol consumption are the contraindications for giving TPT. Pregnancy or a previous history of TB are not contraindication for initiation of TPT. Then if we evaluate for TB disease and the test for TB disease are negative, then again, and there is no contraindication for TB, patient should be treated with the TPT. But if the test for diagnosing TB find out that there is active TB, then patient to be initiated on TB treatment. So the key consideration for assessment of eligibility for TPT and people living with HIV for W4SL, that is 4 screen symptoms are cough, fever, weight loss, night sweats. Then frequency of symptom screening, it should be done at every visit to the health facility or whenever there is contact with the health worker. Chest radiography, not mandatory although desirable, may be considered where facility are available and human resources and health system capacity permits for doing this. Diagnostic test for TB, if screen test is positive, WHO recommended rapid diagnostic tests like the Gene Expert or lateral flow LEM assay among seriously ill people living with HIV as per national guidelines. Tests for TB infection like TST, IGRA or TB antigen-based tests if available. Then contraindication for TPT we just discussed, acute hepatitis, then heavy alcohol consumption and peripheral neuropathy. Then concurrent use of other hepatotoxic medications such as nevirapine or history of hypersensitivity to any of the drug which are used in the TPT. Then counseling to be done regarding information on TB infection, need for TPT, schedule of medication collection, medication adherence, follow-up visits, etc. Then tests for TB infection are either tuberculin skin test or IGRA test can be used for TB infection. Then WHO also recommended the antigen-based skin test. I think it's not at present available in our country. We are not doing in our program. Then these are the various regimens recommended in the latest published WHO guidelines. Here we can see 6 months INH therapy, then INH and rifampicin weekly for 3 months, then isoniazid and rifampicin for 3 months, daily regimen, only rifampicin for 4 months, daily regimen, isoniazid and rifampicin daily for 1 month, and then this combination of isoniazid, pyridoxine and cotrimoxazole daily for 6 months. So here we can see what are the various contraindication which can be used in different category of patients, what are the toxicity, and what are the pill burden in this table we can. So then post-treatment TPT for PLHIV, as we discussed in today's case, in patients with, as per the last published guideline for programmatic management of TPT by NTEP, this in patients previously treated for TB, post-treatment TPT has been considered in 5 to 7 times higher risk of recurrence of TB among people living with HIV. and nearly 90% of these due to reinfection. In addition to post-treatment TPT, ensuring completion of the initial course of TB treatment and effective infection control measures in clinical and community settings. Thus, all PLHIV and CLHV who had successfully completed treatment for TB disease earlier should receive course of TPT after completing treatment of TB. This is as per 21 guidelines, and in the recent guidelines there are some changes that we will discuss in the next slide. So, evidence for TPT for people living with HIV. In a systematic review of 12 randomized controlled trial, including 8,578 patients living with HIV, IPT reduced overall risk for TB by 33%. So here we can see that this TPT is not 100% effective. It reduces the risk by 33% only. And if we do the subgroup analysis, TST positive and TST negative, then reduction is by 64% in TST positive, and it is only 14% in TST, that is tuberculosis skin test negative patient. Then adult and adolescents living with HIV and with ART in randomized controlled trial, isoniazid preventive treatment showed additive benefit to ART in reducing both TB incidence and mortality. Then another RCT, the effect of isoniazid preventive treatment was not statistically significant difference between patients who were positive or negative in TST or ART. So overall limited or low quality evidence in children with HIV for this effectiveness of the IPT. So here we can see it is there is reduction in risk is by 33% if we use in the pre-ART era. Then these are the revised guidelines just came I think last week by National AIDS Control Program. Here we can see that people living with HIV who are 13 years of age and older, they have recommended 1 month or 28 days of isoniazid and rifampicin daily regimen. Dose modification of dolutegravir is not required with 1 HP regimen. Then people living with HIV who are less than 13 years of age, still they are recommending 6 months INH TPT. Pregnant and breastfeeding women also with HIV, only 6 months INH. People living with the HIV and who are on PI, this protease inhibitor based ARV regimens, still they are recommending 6H as the TPT regimen because of drug interactions. PLHIV having contact with DRTB patients and patient is having only mono-H resistance, then the recommendation is 4R daily for 4 months. Then if patient is having resistance to rifampicin or both rifampicin and isoniazid, then recommended regimen is single agent levofloxacin for 6 months daily. Then people living with HIV who are less than 13 years of age and who have successfully completed treatment for TB disease, they recommend 6 months INH as we have given in this today's case also. That we will call as secondary prophylaxis. But now, as per this guideline, for people living with HIV who are 13 years of age and older and have successfully completed treatment for TB disease, immediate TPT as secondary prophylaxis is not required. So what are the evidence for this newly recommended 1 HP regimen? A large randomized open label trial compared the efficacy and safety of shorter 1 HP regimen and reported that 1 HP regimen is non-inferior to 9-month daily isoniazid regimen in people living with HIV from high TB prevalence area and had evidence of TB infection. 13,000 patients were followed for a median of a duration of 3.3 years. The TB incidence was reported by 0.65 and 0.67 per 100% per year in group given 1 HP and 9H respectively. So we can see there is no difference in the TB incidence after completion of 1 HP or 6H TPT. Treatment completion was significantly higher with NHP. So if the duration is short, definitely compliance will be better. So treatment completion rates will be better in the shorter TPT regimen like 1 HP. Serious adverse events occurred in 6% and 7% in 1 HP group and 9. So there is no difference in the SAE or severe adverse event between the two groups. WHO guidelines on TPT also recommends 1 HP as alternative option for the use of across all disease burden settings and target population, including PLHI. So, 1 HP as a TPT treatment option, 2 drugs, isoniazid and rifampicin, duration is 1 month. It should be given daily for 28 total doses. It's because we don't know the effect of HP drugs on pregnancy, so at present not recommended. Contraindicated on all patients who are on PI, nevirapine for NNRTI and PAF, and it can be used with patients using TDF, efavirenz, DTG and REL without dose adjustment. The common side effects are hepatotoxicity, hypersensitivity reaction, rash, GI upset, and orange discoloration due to rifampicin. Peak concentration is increased if given with meal. So these are the doses. 2 pills to be given if we are giving 300 milligram and 300 milligram of isoniazid and 600 milligram of rifampicin. And if we are using rifampicin 300 milligram, then 2 pills of rifampicin and 1 pill of isoniazid 300 milligram. Then if we are using 150 milligram rifampicin, then 4 pills of rifampicin and 1 pill of 300 milligram of isoniazid. So management of interruptions, if after initiating on 1 HP, if the interruption is less than 1 week, then if more than 23 doses have been completed out of 28, then no action is required, just complete the remaining doses. But if less than 23 doses out of 28 expected doses in the regimen were taken, resume the treatment immediately upon return and add the missed doses to the total treatment duration to complete the course of within a maximum of 6 weeks. So it means if a patient has taken only 20 doses and then patient returned back within 1 week, so then we have to complete 28 doses plus whatever dose he has missed. If 5 doses are missed, then patient will be given total 28 plus 5, 33 doses. If the interruption of more than 1 week, then if more than 7 consecutive doses are missed, consider restarting the complete course of 1 HP again. But if more than 7 doses were missed intermittently, resume preventive treatment immediately upon return and add the missed doses like we have done in the previous case. If adherence to 1 HP is not possible due to daily doses, then consider discontinuing it and offer 3 HP weekly HP, isoniazid and rifampicin if that regimen is available. Then treatment outcome of TPT with 1 HP, loss to follow up in 1 HP, TPT interrupted by person for 10 consecutive days of 1 HP. Then total duration is 1 month. This we already discussed. Then how protective is TPT? Efficacy of isoniazid preventive treatment ranges from 60 to 90% among all population, not only in HIV. So the protection is not 100%. It is varying in different studies from 60 to 90%. Various countries, this TPT in people with HIV reduce the risk of active TB by about 1/3. So in HIV population, the risk for developing TB disease is reduced by only 1/3. That is only by 33%. IPT and HR reduce mortality in people with HIV. In another study from Brazil in tuberculosis skin test positive people with HIV reduced TB risk for at least 7 years after giving 6 actual TPT. Then in this another study in South African gold mine, people who are at high risk of TB transmission, then incidence is reduced by 58% while on 9H, but risk quickly returned after stopping TPT. Then another study, 6H reduced the mortality by 37%, independent of ART and baseline CD4, and benefit sustained for at least 6 years after randomization. So how we need to repeat? Do we need to repeat or restart the TPT? So no evidence to date on utility of repeated course of TPT. To repeat course of TPT may be considered among people with or without HIV following a fresh exposure to infectious TB patient based on clinical judgment. A high TB transmission setting in WHO recommends 36 months of isoniazid for people with HIV in high TB transmission setting. WHO recommends. This another WIP-3 TB trial among people with HIV on ART compared the effectiveness of 3 HP given once or twice within 14 months and against one course of 6H. Treatment complete. The conclusion were of treatment completion was better with 3 HP. 24-month follow-up showed similar rate of incidence of TB, rifampicin resistant TB, and mortality between those receiving multiple courses of 3 HP and those receiving single course of 6H. So no additional advantage of repeating the TPT courses. Is it safe to give TPT? In general, TPT is safe and shorter regimens make it more tolerable. A systematic review of 23 RCTs and 59 non-RCTs found that hepatotoxicity was found around in 1% 3 HP regimen, 0.01% in 3 to 4 months of R, 6.3% in 6H, and 3.1% in 9H. Withdrawal due to adverse events was only, there we can see it's very low. And the rate of adverse events were also very low. And flu-like reactions in 3 HP, which is usually associated with rifampicin-based regimens. So here we can see 2.2% in 3 HP. So we can see that TPT is really safe. So one question also there, does TPT fuel emergence of drug resistance? So if once this systematic review based upon 6 randomized control trial of rifamycin-based TPT versus active control or placebo group, they found that only 6 patients, that is only 0.09% less rifampicin resistant cases in 6,808 individuals receiving rifampicin based TPT. So it's almost negligible. Another trial also showed only 0.01% rifampicin resistance in patients who received alternative regimens other than rifamycin based TPT. So here we can see there is only negligible risk of development of rifampicin resistance in patients receiving TPTs. So similarly, we can see in other this systematic review also, the rate of development of resistance is very low. So how to manage TPT interruptions? For 1 HP we just managed. So similarly, here we can see adding missing dose at the end if more than 80% of the total doses were taken during expected time, and regimen can be completed within 133% of the expected duration. If the 2 conditions are not satisfied, then we have to restart the TPT. So with this, thank you everyone. And now we can discuss if there are any questions.
Yes, sir. Thank you, sir. Thank you for such an excellent didactic and talking us through the guidelines and making us understand.
Before we go for the further discussion, I just want to make some clarification, as the ART Center must have received the recent guidance from the NACO last week. So the statement which used to be said by the CTD and our guideline used to be say the same thing. For the second, it is regarding the secondary prophylaxis. The TPT also provide additional protection when given immediately after completion of TB treatment in PLHIV. So this has now a limitation. It is not applicable for all the PLHIVs. PLHIVs who are aged less than 13 years. So the same thing will be applicable for those CLHIVs. But those who are aged 13 and above, the secondary prophylaxis is not required, as sir has shown the recent guidance which is written in the letter for PLHIV who are 13 years of age and older, have successfully completed treatment for TB disease. Immediate TPT is as secondary prophylaxis is not required. So this is the recent update. So now onwards, the ART center has to go with this recommendation. And one more thing, what sir has said, and in this letter, there are number of regimes of TPT are written in the preferred TPT regime. So these regimes like 4R, levofloxacin, so these are the regimes which are being given by the CTD. National AIDS Control Program has not yet adapted these regimens for the TPT. So in NACP program, we have two regimes. One is 6H, which we were giving it prior also. And now we have adopted the new regime, which is 1 HP. Isoniazid and rifampicin 28 doses. So this would be a new regime for PLHIV who are aged 13 years and above. So these are the recent updates which I want to reiterate.
So, sir, there's a question that she has raised that it's saying immediate secondary prophylaxis is not recommended. So it's like above 13 years of age, maybe not immediate, but are they just not recommending secondary prophylaxis above 13 years of age, or is it that immediately you should not give it? Like for PLHI, you are older and completed, immediate TPT-SA is not required. So can we delay TPT for them?
No, don't delay. It means it is at present was the recommendation as per 2021 guidelines for that once patient complete the anti-TB treatment, we have to initiate the patient on TPT. That is secondary prophylaxis. So this is now it is not required.
Okay. And under 13 years, you should.
Yes.
Okay.
Under 13 years, still it will continue after completion of the treatment. Secondary prophylaxis with this TPT.
Okay, sir. Yes, sir. Sir, considering that we have HIV population and there's already a pill burden and there's already peripheral neuropathy, the contraindications for these rifampicin based and isoniazid based TPT. So you think that giving 1 month won't add to the adverse effects? I mean, giving 3 months and then this adoption is right, and then we give it for 1 month instead of 3 HP, like which was delayed for 3 months. So maybe the adverse effects didn't come so quickly, but now we are giving 1 HP.
Because these regimens are as per evidence available, and we have the sufficient safety data of using these drugs.
Okay.
So as compared to we have seen this trial, they compared it with 9X, which is considered as more neuropathy causing regimen. So at least now instead of 9 months, we are using the drug only for 28 days.
But there's no head-to-head between 3 HP and 1 HP.
At least there is.
He had also attended the training done by the TPT, the TB prevention therapy. So they have presented on the evidences which were recently collected that 1 HP has, if you compare with 3 HP, 1 HP has good adherence as compared to 3 HP because you have to take a dose weekly. So people might forget to take the dose. So in 1 HP, in 1 month, you can complete the regimen.
The commitment level is higher.
Yeah.
Shorter the regimen, more will be the compliance.
Answer.
Even though that is weekly, but if Dr. Jyoti has said that if even a single dose is missed, then there will be a gap of 2 weeks.
Yes.
3 HP basis.
Treatment compliance is utmost required.
So as we have seen that as case presented by Dr. Saab, that why this patient after completion of course of anti-TB treatment, then secondary prophylaxis for 6 months, and after a gap of around I think 3 to 4 years, he again developed TB. So as we just saw in HIV patients, the protection with the 6 months isoniazid hazard is only 33%. And if we divide in TST positive and TST negative, then it will be around 67% in TST positive protection, and in TST negative is only 14%. So, because it is not protecting 67% of cases with the development of TB, recurrence of TB. So, that's why this patient has developed TB again.
And another cause may be because he has defaulted the treatment for 15 months. So that could be another reason for failing
TPT failure.
Reoccurrence of the TB.
It's a neurological failure.
Most of the recurrence are due to reinfection by a new bacteria. 90% of this recurrence is due to reinfection. So patient not taking ART and he must be visiting in the community, so he might have got the reinfection from a new source again.
And all the scientific data is patient who have adherence to the ART, all this TPT data. So they are adhering to that. So they rule out immunological failures and virology. Those confounding factors are not there. But in field condition, if patient is not taking the basic ART, then you cannot blame TPT for that. It's a basic failure. It's a basic your natural disease of the patient that is happening.
And if you see the viral loads also, the viral load was done in October 23. It was 19,500 something. So that means he was either failing or because he was not adherent to the ARVs. So the viral load goes up, and because that could be a reason that he got relapse or reoccurrence of TB. So your findings also suggest the same.
Basically, TPT is a reinforcement, and the ART is still the foremost thing that prevents you from the opportunistic infection. And it is the backbone that still prevents TB in the VLHIV population, and it reduces the mortality and reduces the opportunistic infection. So ART still holds its position. You cannot ignore ART just because you have given TPT. So ART is still an upper hand than any other preventive treatment for anywhere. So if you have any questions, I would like to ask the case presenter and his doubts clear.
Any question in the chat?
Any question?
Yes, madam, I understand clearly the new guidelines of TPT. The patient reoccurrence as per SARC code, it may be the reinfection. So viral load is also high, but the recent viral load it shows 1,600 only.
Yes.
Some enhanced adherence counseling. That maybe the adherence is improved. So that's why I understand. No other questions.
And so another thing that the guideline has pointed is chest X-ray is not mandatory, but I think practically we should be advising chest X-ray.
If it is available, it should be done.
Because in the HIV population, this fever, it's like very vague, it's very something that doesn't involve that, and especially extrapulmonary TB, that also we have to look for factors. So I think HIV population, I would like to say, because we cannot just rule out viral stop fever.
Before initiating TPT, we have to rule out active TB disease. So first one is the symptom complex, then second is X-ray. If it is available, then we should make all our effort to get the chest X-ray.
And even look for lymph nodes and any form of extrapulmonary TB. So there's another question by Arindam Mukherjee. Please unmute and ask your question, sir.
Yeah, thank you for the nice presentation, sir. Actually, I want to know why we went for 1 HP. We are okay with the 3 HP. Is there any specific reason we went for 1 HP? Is there any any contradiction or something case study is there?
As we have seen, these all recommendations are based upon the evidences available. As we just discussed the evidence for 1 HP, and they found that it is not inferior to 9H regimen. So that's why they have recommended, and maybe due to this in 3 HP, there are chances that patient may miss. If one patient has missed 1 dose, then there is gap of around 2 weeks. So because of that, because shorter the regimen, more are the chances of compliance. So that's why I think they have recommended because we just received this communication as a circular. Exactly what is the basis why they have selected, still we have not got that details. But I think that is all based upon that recently this launched WHO guidelines. They have recommended this regimen also.
Thank you, sir. Thank you for the presentation.
I think we can go ahead with the post-test poll answer.
So our first question was, what are the contraindications of TPT in PLHIV? Option A was acute hepatitis, regular and heavy alcohol consumption, or symptoms of peripheral neuropathy. Option B was concurrent use of other hepatotoxic medications such as nevirapine. Option C was history of hypersensitivity to TPT. And option D was all above. So the correct answer is option D. All above are the contraindications of TPT in PLHIV. Question 2 was, which TPT regime is safer in children less than 13 years of age, pregnant women and breastfeeding women? Option A was INH and rifampicin daily dose for 28 days. Option B was INH daily for 6 months. Option C was both A and B. Option D was none of the above. So correct answer is option B, INH daily for 6 months as per the latest guidance we have received.
Thank you everybody for joining us. But first and foremost, I would like to thank our expert for today. Thank you, sir, for making such an informative session today. And I thank our case expert also today because for sharing a wonderful case and opening such an important discussion today.
So I thank all our participants, our case presenter for bringing out such an interesting case on TB preventive therapy. I give my special thanks to our case expert who has given the directive on this and made our doubts clear. I thank Dr. Ananya for moderating the session, and I thank all our participants who have joined the session today and got the and attended the insightful session. And last, I thank our team for moderating this of the curtain. Thank you so much. Thank you. Bye.